In this conversation, we're going to be talking about the duty to warn, which often comes up in the practice of behavioral health, but it may come up in any physician's practice or in any counseling practice that you may be managing. First, let's talk about the history of the duty to warn. The seminal case of Tarasoff versus the Regents of the University of California, you may be familiar with. In that case, a psychiatrist at the University of California had a patient who said that he was going to kill his fiancee. The psychiatrist was adequately convinced that, in fact, he intended to do it, he had the wherewithal to do it, and he was gravely concerned about the well-being of the fiancee. He left the patient, called university security to stand outside the door of his office while he went to consult with the general counsel for the university. The general counsel reflected on the situation and advised him that certainly under the ethics of psychiatrists at the time, it was improper to divulge any information about what a patient had told him in therapy. And that was a well-established rule at the time. The Supreme Court of California announced that from that day forward, from the day of their decision, while they appreciated the advice of University General Counsel, which was in fact correct up to that date, they were announcing a new rule that in fact a psychiatrist or someone in behavioral health had a duty to warn in the setting where there was an identifiable victim and the psychiatrist was convinced that the patient had the wherewithal to carry out the crime they planned to do um, and had the means to do it. The um, Unfortunately, in that case, the fiance was killed, and the parents of the young woman brought a lawsuit against the psychiatrist. The psychiatrist was not found liable in that case because up until the court announced the rule after the fact, there was no duty to warn. But Tarasoff has been followed by almost every jurisdiction in the United States. We anticipated that it would certainly be followed here in Virginia, and the case finally came to the court in the case known as Nassar versus Parker. It was a case that arose in Virginia Beach. It was a strikingly similar sort of circumstances to the Tarasoff case in that a patient was in a psych hospital. He was voicing that he was going to kill his fiancee. He was a former Marine, I believe. Um, the psychiatrist didn't really comment or document anything about whether he was convinced the patient would carry it out or not. But there was certainly clearly a voiced a risk for the psychiatrist. Unfortunately, the patient did leave the facility and killed his fiancee. Dr. Parker was sued by the family for the wrongful death, and we anticipated that the Supreme Court of Virginia would follow in the footsteps of the Supreme Court of California. They, in fact, refused to do so. The Supreme Court of Virginia stated that the fruits and nuts of California had it all wrong, that there was no special relationship, which is an important concept in tort law, and without the presence of that special relationship, i.e., the ability to control the actions or the ability to protect the victim, that Dr. Parker owed no duty to the deceased young woman. That was quite surprising to all of us in healthcare. We didn't see that one really coming. We thought that it was a slam dunk that Tarasoff would be followed. Um, the General Assembly, when it next convened a couple of months later, quickly fixed that situation by passing a statute that now requires in Virginia that Tarasoff be followed as a matter of statute as opposed to case law decision. And that statute has these components to it, and you'll find in whatever state you might work that whether it's by statute or by Supreme Court decision, these are kind of common denominators. One is that the situation is a mental health care provider, and in Virginia that's described very broadly to include almost every licensed healthcare provider, but particularly focused on the psychologist, the licensed clinical social workers, the psychiatrist who are certainly directly involved, but a family practitioner, for example, may be rendering behavioral health care services. If that mental health care provider has a reasonable belief that the patient is intending violent behavior or serious harm, that it is a specific and imminent threat to a readily identifiable person, then, and that the patient has the intent and the ability to carry out that threat immediately and imminently. And of course, there is an added factor there as to children that there's a duty to protect. But let's back up for a second about that readily identifiable person. Classically, I always taught that that would be a single individual, that the statute really was talking about the fiance sort of situation, who always seems to take it on the chin in these cases. But I am of a mind that in fact that may be broadened these days. If a psychologist has a patient who says, I'm going to blow up Atlanta because of the unfortunate situations that have occurred, and you name the city, whether that's Orlando, Boston, Blacksburg, Las Vegas, any of those places, that may be sufficient to meet the criteria for the readily identifiable person these days, because society's mood has changed on this point. If that is the case, then there is a duty on the healthcare provider to take certain steps. That is, first, he or she can seek involuntary commitment of the patient, which, as we've talked about in previous sections, is a fairly cumbersome sort of process. They can notify the police, which is certainly very easy. Quick phone call. If that is the steps that your provider is going to take, I recommend that they document who they spoke to, when they made the phone call, what was described, and so forth, because the police have been known to have a tendency not to immediately take action on those sorts of phone calls, potentially leaving the behavioral health person kind of in the lurch there. They can notify the potential victim, and certainly if that is a sole individual, that is relatively easy sometimes. It may not be if you don't exactly have the contact information of that individual, but if it is the city of Atlanta, that may be a little more problematic. The fourth action that is described by the statute is that the provider can take action to prevent harm while the police are summoned, which means, I guess, kind of keep them distracted, show them shiny objects, play with them, whatever. And the last is to render therapy in the session until the threat reasonably likely to have resolved. That is the most dangerous of the four actions that one can take, because obviously this is often looked at in retrospect. And how did you reach the conclusion that the threat has reasonably resolved? And this takes a lot of judgment. And it is also equally challenging, because I appreciate that quite often when patients are admitted to a behavioral health facility, they may be voicing threats against somebody, a girlfriend, a husband, whoever put them there, that sort of thing. And those threats often resolve and there's really no risk whatsoever. But on the flip side of that is that many patients are also quite bright, and they realize that they aren't going to get out until they stop talking about getting even with somebody or harming someone. And they certainly lie from time to time. So it is problematic to undertake that sort of an approach to meet the obligation. One can also use more than one of these approaches. It is not terribly difficult to notify the police. You might add on to that trying to contact the victim. You may think that a TDO is the right way to go, whatever combination you feel appropriate. One of the rights that is not given to a provider is the right to detain someone. You can't simply lock them in a room, tie them up, or drug them as a way of fulfilling the obligation required by this statute. You can seek a TDO, you can seek an emergency admission of some kind, but you can't take the law into your own hands, so to speak. If you do take any of the five actions that would fulfill the duty then you are in fact granted immunity for any breach of confidentiality that may cause. You are also granted immunity for failing to predict violent behavior in the absence of an explicit threat. And the goal of that is we don't want people overcompensating here, that every obscure reference is interpreted as, oh my gosh, I have to call the police or I have to seek a TDO for this patient. The goal is to reasonably make the assessment, and if you reasonably are convinced that in fact there is a risk, you have an obligation to act. There is no obligation to take any steps that are not articulated in that list of 5 potential steps. As you might guess, HIPAA is a little more vague on these points. This is how it reads. Go with the Virginia statute. It's pretty clear. It's a nice summary of the classic Tarasoff decision. If you appreciate that your client is a risk to someone, you have an obligation to act, and I would encourage you to do so.